Great. Wonderful. And I do hope some of these recent findings from the social behavioral sciences can inform our panel discussion for later today on women and also later on analytical treatment interruptions. So here's my proposed outline for today. I would like to discuss some of our social science results from the ACTG 5366 clinical study, which was done entirely in women. So Dr. Eileen Scully will present the biomedical data at CROI in the coming days. There's still an embargo on these results, but we have permission to show some of the social sciences, some of the results from the social sciences. We will also discuss some of the key findings from our recent survey on preferences for virologic control strategy, because we think these could inform the discussion later today. And we'll also discuss proposed plans for the fresh cohort preparation, and we would love your input as well. And we'll have questions for discussion going into the panel discussion. So first, this slide shows the ACTG 5366 study design. This was a randomized, open-label, exploratory study comparing the use of tamoxifen and vorinostat, with vorinostat used alone in 30 women living with HIV in the US. And here, vorinostat is the latency reversing agent. This was the first HIV cure-related study designed entirely for women, and the main hypothesis was that the treatment with the selective estrogen receptor modulator tamoxifen would enhance the ability of the HDAC inhibitor to reverse HIV-1 latency. And as I mentioned, Dr. Scully will present the biomedical data at CROI. So here I will focus on the social behavioral science data. The manuscript is currently under final review and should be published soon in AIDS Research and Human Retroviruses. And of note, this study did not involve a treatment interruption. So this slide shows the 2 time points for the social science questionnaires. We did surveys at entry and exit with the women, and we were invited to be part of the study team from the very beginning. So it helped us get quality data. We also showed the various social science domains that were captured at each of the time points. So these were decided with close consultation with the community representatives on the protocol, including Kate Starr and David Evans. We also had very limited data on how women would perceive HIV cure research participation before that, so we are glad that this could contribute to that literature. This was also the first time that we integrated participant surveys like these in an ACTG cure clinical trial in the US, and these were brief surveys and not extensive interviews. So we learned a lot from the implementation, and also the methods have evolved since then. So this slide shows answers to the question of what would an HIV cure mean to women who participated in the 5366 study. So 8 said it meant not having to take HIV medication. 5 said cure would mean having HIV completely eliminated from the body. Others made references to freedom, hope, empowerment, and living without fear. For example, it means liberation from HIV stigma and a revolution of medical proportion. Others said it would mean improved immune function, a healthier status, and not having to visit the doctor so often. When we asked about the primary reason for deciding to join the study, 2/3 made a reference to helping find a cure for HIV or altruism. For example, I want to be an example for other people that are living with the virus, that there's research and medicine out there. 2 women said specifically that they wanted to be cured of HIV. This does not necessarily mean that they misunderstood the study, but rather that they may have hoped that by participating, we might get closer to a day where they are cured. So they expressed therapeutic optimism. When asked if they were satisfied with the informed consent process, 28 out of 29 women said that they were. One woman mentioned, the doctor explained the study thoroughly, and that made me feel that I was not in danger. Another participant said, the information appears to have a clear plan to clear the virus. Yet another said, because it was clear and simple and it helped me understand what medication I will be taking and the side effects and everything. In terms of the possible benefits of a future HIV remission strategy that would most positively affect the lives of the ACTG 53 66 participants, having HIV completely eliminated from the body was the most popular answer. This was followed by being able to stop taking HIV medication, not having to think about having the virus, and not being at risk of the diseases and conditions that often go along with HIV or are made worse by it. 2/3 of participants mentioned wanting to have a better quality of life, and one woman specifically answered that a most important benefit to her would be putting away the stigma that comes with the status. When asked if there were perceived risks of participating in the study, 6 out of 29 said that there were no risks. 21 said there would be risks, including those listed on the slides, and one woman said there would be risks, but did not know what they were, and we'll talk about the implications of that. So when asked if there were any benefits of participating in the study, 24 out of 29 women said yes. A few women made a reference to helping find a cure for HIV. One mentioned the psychosocial benefits of being in a cure-related study, and others mentioned compensation as a benefit. Interestingly, 8 out of 29 women said that negative feelings about having HIV played a role in their decision to participate. As we can see, stigma still appears to be pervasive in many of the participants and the women's lives. So now we discuss the exit survey. So women have participated in the study, they've completed the study, this is their final study visit. So 27 women completed these questionnaires. 26 out of the 27 women would recommend the study to others, and one did not know. So almost all of the women had a really great experience and felt like it was useful to be part of the study. 20 out of the 27 women stated benefiting from being in the study. And these perceived benefits included receiving test results, learning about different HIV medications and HIV reservoirs, learning disciplines about taking medications, and close monitoring. Some women clearly perceived the study compensation as a benefit of being in the study. And as we can see from this slide, very few participants reported actual problems of being in the study. In fact, 24 out of 27 women did not report any problem. 2 said that HIV cure research was really complicated to understand. 2 reported potential stigma, and 1 mentioned parking problems. 1 participant said that there was too much blood at each visit. So what did we learn from doing participant surveys with women? Well, we identified societal and personal motivators of participation, understanding of risks, and minor misconceptions in some trial participants. The results point to the need for continued engagement and clarification of expectations in cure-related studies. Stigma still plays an important role in women's lives and in their decisions to participate in studies, and also compensation clearly played a role in their motivations to participate. Almost all women had a very positive experience being part of the study and would recommend the study to others. We also need to appreciate here the psychosocial and effective aspects of HIV cure-related research participation, I think particularly for women, and we were able to successfully integrate social behavioral sciences as part of an ACTG biomedical HIV cure-related study. So here are some of the implications of the findings. We should avoid the word cure in informed consent forms and use precise language. We should also increase the readability of informed consent forms and simplify risk information. We should appreciate the psychosocial aspects, ascribe value to the lived experience of study participants. We obviously need more research to understand the role of stigma and self-image in decisions to participate. We also need to work on reducing barriers and enhancing facilitators, aligned with what Liz mentioned earlier. But we also need to understand factors that are related to treatment interruptions. Again, the 5366 study did not involve a treatment interruption. So we have the results under final review in AIDS research and human retroviruses, and hopefully the manuscript will be available to the community very soon. We also continue our advocacy to integrate and monitor participants' psychosocial experiences, particularly during trials involving treatment interruptions. So there was a consensus workshop published last year that did advocate for this issue as well. And there was also an excellent meeting organized by the Forum for Collaborative Research in Washington, D.C. in 2018. And we did advocate for the different items mentioned on the slide. So we prioritized the vision of the NIH Revitalization Act. And obviously some of the issues are not unique to women, also a minority population. We know Rico, for example, is interested in this research, as well as Danielle. We need to engage diverse people in research. We should also design studies with female relevant strategies. And if it's a female relevant strategy, we should ensure that we have enough women participating. We should also account for sex and gender differences in cure studies and build analyses into the protocols and have minimal enrollment for women. We should ensure better reporting of results, even if N is 0. We should have analyses broken down by sex and gender, and this also applies to animal research. We must think beyond risks and benefits, and as a field, we also may need more standardization of assessments to make meaningful comparisons across studies. And I think Liz talked a little bit about that, because we're dealing with the law of small numbers. We should also include social behavioral scientists to understand factors that would facilitate recruitment and retention. We need to pay attention to what women need and what they want, and also forge a pathway towards a patient-centered HIV cure research agenda. So now we'll show some of the key findings from our 2018 survey, which was really meant at engaging diverse women across the United States on HIV cure-related research. So interestingly, when we looked at perceived risks by gender, compared to men, cis and trans women were more likely to be concerned about the following risks. The risk of the increased likelihood of transmitting HIV to others during a treatment interruption study. So this will have important implications for our discussion this afternoon around treatment interruptions. And also overall, we found that women may have been more averse to clinical risks, particularly serious risks. When we looked at perceived motivators or perceived benefits of HIV cure-related research, there was a lot more categories that were statistically significant differences. Women seem to be more motivated by having regular access to a study nurse, or by financial compensation, or by receiving basic support for things like transportation. So although there were diversity in the responses, we should definitely pay attention to these motivators up front as we design the studies, because these motivators appear to be particularly relevant for women. Now, when we looked at the likelihood of switching to new scenarios of HIV remission strategies by gender, we also found that women and men may have slightly different priorities. So, for example, compared to men, cis and trans women were more likely to want to switch to a new scenario despite having to go to the clinic or the lab more often. But they were less likely to be willing to switch because of temporary worse side effects or a small increase in the risk of developing health problems later in life, like cancer. They were more likely to want to stay on ART if the new strategy would not increase their life expectancy or would not improve their quality of life, or it would require them going off ART to find out if it would be effective, and that's the treatment interruption. When we looked at the acceptability of trade-offs under the new scenario, when we disaggregated the data by sex and gender, we found that cis and trans women were more likely to be very bothered or to find the following factors to be unacceptable, including procedures that would occasionally cause mild to moderate pain, or also if the new strategy would involve biweekly injections or infusions for several months before it started working. We also looked at acceptability of oral daily medication versus long-acting ART injectables versus remission. We know that long-acting formulations are around the corner and may blur the boundary of what it will mean to be in remission. So we found some interesting differences by sex and gender. We also found some interesting differences by age groups. And we worked with Drs. Paria Saberi at UCSF, and we just submitted a paper in AIDS research and human retroviruses as well, looking at these differences by age group. So when we ask about willingness to try an HIV remission strategy to avoid the long-term consequences of long-term treatment, 73% of women were willing, but the results differed by gender. Men appear to be more willing than cis and trans women, and these results are also statistically significant at the 0.04 level. We also did several analyses using bivariate methods, and we found some really interesting differences by sex and gender in terms of acceptability of different clinical risk categories. And then from our multivariate data, we found that from a patient participant perspective, we will definitely have a high threshold of safety to move these interventions forward. So in general, we found an aversion towards clinical risk. Here in the multivariate model, we did control for sex and gender. So we created a heat map of the results across different scenarios. And what you see are odds ratios. They're statistically significant at the 0.05 level or less. So if it's an odds ratio that is less than 1, you know that this is a deterrent to wanting to participate. So we found interesting differences here across different scenarios. And the data are available in this paper that was published last fall in AIDS research and human retroviruses. Obviously, we think it would be interesting to do additional surveys in low and middle income country settings. And also Danielle Campbell from the ACTG Community Scientific Subcommittee is now in process of writing a qualitative paper on these results. So some of the key findings: we'll need to provide a variety of therapeutic options to people with HIV in the future. We'll need decision tools and education materials to help patients and HIV care providers make decisions. There are important sex and gender differences, also in perceptions of risks and preferences for HIV control strategies. More research will be needed to understand patient preferences in diverse populations. Long-acting formulations will also be associated with implementation challenges. And we also need to further investigate perceptions of treatment interruptions that will be required for some of these protocols. We also had the pleasure of implementing interviews with trans women living with HIV in the US, in the Baltimore area, with Dr. Tonio Petit, who is now at UNC Chapel Hill. So this manuscript is under final preparation, under final co-author review, and will also be submitted to AIDS Research and Human Retroviruses in the coming weeks. So here were some of our key findings. In general, trans women had positive views about HIV research in general, and also positive views about the healthcare system because it helped them achieve their health goals and also gender-affirming care. There was a mix of HIV cure research optimism and skepticism. In general, there was a desire for complete cure. Some believed a cure already existed. There was an aversion to HIV treatment interruption, which was perceived to be more dangerous than hormone interruptions. We have some really interesting quotes from women. I can read some of them. For example, but HIV is more important than the hormone pill. That hormone pill did not make me. Right now, I'm undetectable. The hormone pills cannot do that. That hormone pill is not as sturdy. It's not as strong. It's not as healthy as that HIV pill. Or, that's not life-threatening. And the HIV medicine, that's life-threatening. Or another quote, well, if it's a pill, see, I'm already taking shots in my butt, sugar shots in my hip, sugar shots in my fingers, no more poking. So in general, there was also an aversion to needles in this group, which is interesting, knowing that trans women have to take injections. There were also a request for special protections to be in place for trans women, the need for basic respect, but also special protections around transportation for from them going to their study visits. And also trans women identified many community priorities besides HIV research. Overall, they had excellent experiences with their current medication. This provided stability in their lives. They were anxious about switching HIV regimen. The trans women also identified possible risks and burdens and benefits of being in these studies, but some wondered whether their body could withstand so many changes. There was also overall a receptivity about cure-related research strategy. The women were able to formulate different gut reactions about different strategies, really interesting data. And then there was also a strong desire to receive more information, and they also wanted opportunities to connect with other trans women. So finally, we also had the privilege of visiting the FRESH site in November 2019, and I was blown away with the FRESH site. I think Krista and her team are doing really wonderful work preparing the community for this kind of research. So this slide shows some of the deliverables that we were thinking that we may want to think about to prepare communities around HIV cure-related research or post-treatment control research. We had a long discussion with the local community advisory board to not use the word cure. Post-treatment control research may be more appropriate. We want to prevent the therapeutic misconception or curative misconception. We think we'll need a lot of information in lay terms for the communities, particularly around BNABs or LRAs or ATIs and all these acronyms. Also about durable suppression. We'll need different patient engagement tools, simplified vignettes for the study participants, a really good test of understanding, simplified study visit calendars, and then different one-pagers. We also should collect social harm and then look at different role-play scenarios for training. Role-play scenarios may be more effective than extensive checklists. We'll also have to be really mindful of the local context. And when we did some translations from English to Zulu, we were really surprised. If we think cure-related or post-treatment control research is complex in English, once we translated in Zulu, it seemed even more complicated. Post-treatment control research was translated in Zulu as Sindezeleka Kwegwanwane and Gapangle Kwemishanguzo. And when we back translated this in English, we obtained suppression of HIV without ARVs. So that's interesting in how the women and the community advisory board conceptualize this type of research. And obviously we'll need a lot more engagement with the community to make the science accessible for the local context. But wonderful work by Krista's team. The FRESH program is truly a wonderful and unique program. It does so much for women locally. So in closing, I would like to close with some potential questions for your input that we can discuss in the panel. So how do we help women and how do we support women to participate in HIV cure-related studies, particularly those involving analytical treatment interruptions? Obviously, we need to see women as allies, as Liz mentioned earlier. But we should also look at perceptions of HIV care providers. We should look at perceptions of burdens and commitments. I think that's something Beth Peterson from the Beat HIV CAB will discuss. Also at perceptions of risks and potential social harms. An important question is, are women willing to interrupt treatment, and under what circumstances? Are there differences between high-income countries and low-income settings, and between the acute and chronics? Are there special considerations, safeguards, and protections that should be in place for women during treatment interruptions? I think Linda D. will discuss a proposed standard of prevention during ATIs later this afternoon. We will also need to think about factors specific to women. We will also need to adapt the standard of prevention to different contexts, including the Durban context, for example, particularly as we try to harness the HIV prevention, treatment, and cure continuum. And then what should be priorities for networks like the ACTG, particularly as several of the trials will be shifted from the Martin Delaney collaboratories into the ACTG network. Danielle Campbell and Angel have done wonderful advocacy work within the ACTG to raise the profile of social behavioral sciences. And then how much leverage do we have as a community to bring these topics to the forefront of the agenda? So obviously a lot of questions we can discuss. There are a lot of people to be thankful for, and more people are interested in behavioral and social science research, which is really amazing. So this slide shows the different folks who've contributed data for this presentation. In particular, I'd like to thank David Evans and Danielle and Tonya Petit, as well as Liz Barr and Beth Peterson from the Beat HIV CAB, who's truly a champion when it comes to women's issue. And then, of course, the work with Dr. Schooley and Dr. Gandhi and with Krista with the FRESH cohort. So thank you all so much, and I'm happy to answer questions.
Thank you, Karine. We did have one question about some of the findings that you had found, if they were in line with other male studies.
So it depends which study you're talking about. For the 5366 study, we didn't have a control group. So as we move forward, for example, with the ACTG, it will be important to implement the same surveys with men and women, so we could really look at sex and gender differences. And so, you know, that's going to be really important to disaggregate data by sex and gender. For the survey, the data with women were aligned, but there were some interesting differences by sex and gender, as I showed, and I'm happy to share the paper. We tried to juxtapose the data for women versus men, so we could clearly see the numerical differences and also the differences that were statistically significant.
Thank you.